Great, thank
Thank you.
you. We do have one more panel, and as they're coming together, I'll let you know who's on it. Before we launch the panel, I do want to note we had two papers that were originally slated for this panel that we did not. We lost our speakers for them. Thankfully, the papers themselves are available on the website, but we have a paper by Minaj and colleagues that describes a health justice policy tracker that looks at policies adopted around the world designed to advance health justice for vulnerable populations. And unfortunately, the author's not available. Similarly, Lasse Falk and colleagues wrote a paper on public perceptions of lockdown policies in Europe, showing that socioeconomic status did play a factor in how harsh people thought the lockdowns were, as well as trust also played a role. So again, sorry to not have those authors represented today, but want you to be aware of them. We do have three speakers who I'm pleased to have join us as we discuss vulnerable groups and protecting priority populations. Esra Eren Bayindir is a research associate in healthcare management at the University of Hamburg. Jennifer Seager is associate professor at the Milken Institute School of Public Health at George Washington University. And Cesar Gonzalez-Gonzalez is a research scientist at the University of Texas Medical Branch. As with our other panels, we will turn to them sequentially to present their papers. We do continue, for those watching live, to have the opportunity to bring questions in from the audience. And we'll wrap it up with a Q&A before we close out the event. With that, Esra, I'll turn first to you.
Hi, thank you so much for the opportunity to present our work on socioeconomic disparities in all-cause mortality and healthcare use during the pandemic in Germany. This is joint work with Robert Messerle, Tom Stargard, and Jonas Schreier, all from University of Hamburg, Hamburg Center for Health Economics. And we thank German Research Foundation and Federal Joint Committee Innovations Funds for financial support. And I'd like to express our gratitude to Marcela Alschen. We benefited tremendously from her helpful suggestions and inspiring works. Next slide, please. Germany has a universal healthcare system in which 87.3% of the population, including welfare recipients, is covered by statutory health insurance, and 10.3% of the population is privately insured. In the German statutory health insurance system, solidarity with respect to both income and access to care is the guiding principle. Insured people generally contribute the same share of their income, and they're entitled to benefits according to their health needs. And patients can freely choose among almost 1,900 hospitals. Patient co-payments are the same across hospitals, and people can freely choose among the 185,000 general practitioners and specialists at almost 100,000 practices all over Germany. Data on education and income level of the population are publicly available at county level. Hence, we performed our analysis at county level using county level education and income. And there are 401 counties in Germany. Average population of counties is 207,000. Next slide, please. In this paper, we examined how all-cause mortality and inpatient utilization deviated from the pre-pandemic trends during pandemic's first 2 years by education and income level. We studied all admissions, respiratory admissions, AMI, stroke, and appendectomy as emergency care, breast and colon cancer surgeries, hip replacement and tonsillectomy as elective admissions, back pain, COPD, diabetes, heart failure, and hypertension as admission ambulatory care sensitive conditions. Next slide, please. This chart shows the baseline mortality and hospital admission rates for a selection of conditions for the sake of space. Here, low and high correspond to first and ninth deciles of the county level education and income distributions, and all-cause mortality rate as per 1,000 population, All hospital admissions are per 100 population, and the rate is per 10,000 population for the rest of the conditions. So the scale for all admissions and all-cause mortality are different, but the same for the rest of the conditions, just to be able to put them all in one chart. And in the pre-pandemic period, hospital utilization of the counties with low socioeconomic status was higher than that of the counties with high socioeconomic status in general, with the largest socioeconomic disparities in ambulatory care sensitive conditions, so diabetes and heart failure in our chart, which is presumably caused by higher healthcare needs of the socioeconomically disadvantaged population. One striking finding is that for the rest of the conditions, socioeconomic disparities were quite low, especially keeping in mind that we are comparing first decile to the ninth decile. Next slide, please. This chart shows the all-cause mortality and hospital admission rates for the pre-pandemic period and 2021. All-cause mortality increased and hospital use decreased for all socioeconomic groups, but education was more strongly associated with a change in hospital use than income. And the decline in hospital use was limited for the conditions we studied, except for ambulatory care sensitive cases. The impact of the pandemic was the most pronounced for the counties with low education and the least pronounced for the counties with high education. Next slide, please. Here we see the changes in socioeconomic disparities in all-cause mortality and hospital admissions from the pre-pandemic period to 2020 and 2021. Here, a negative number corresponds to an extra decline in hospital utilization rates for the relevant group. For example, for diabetes, hospital utilization of the counties with low education or low income decreased more than that of the counties with high education or high income in both years. So the changes in socioeconomic disparities were limited, except for the ambulatory care sensitive conditions, for which the socioeconomic disparities actually decreased during the pandemic. And in general, education was more strongly associated with a change in disparities than was income, which might be partly caused by the lower variation in income than in education in Germany. Next slide, please. So we think that the universal healthcare system and the presence of a strong social safety net might have helped mitigate the impact of the pandemic on all-cause mortality and large segments of healthcare use in Germany. Additionally, our findings underline the importance of education. Hence, more guidance to the population with low health literacy might help further diminish the socioeconomic disparities in healthcare use in Germany. Thank you so much.
Thank you. Jennifer, over to you.
Thank you. So I'm presenting our work looking at the impact of COVID-19 pandemic restrictions on adolescent social outcomes. And just to give a little bit of background, while we know that adolescents were less susceptible to COVID-19 related morbidity and mortality, the social containment policies to curb the disease really had some large impacts on their everyday lives, right? So these policies included stay-at-home orders, and most importantly for these adolescents, potentially as the closure of schools for extended periods of time. And in LMICs in particular, the limited access to technology, low provision of resources by schools, these school closures could have sort of greater repercussions on adolescents. And in a couple of settings that we're focusing on today, Bangladesh and Ethiopia, there is also a large concern that with school closures and economic instability, that there may be some impact on early marriage in these settings. And so we can go to the next slide, please. So what we do is we use panel data on 7,000 adolescents who are living in Bangladesh, Jordan, and Ethiopia. And they were all surveyed prior to the pandemic and at 2 points during COVID-19, once early in the pandemic in, say, May to July 2020, and then once later in sort of late 2020 to April of 2021, depending on the context. And the baseline or the pre-pandemic surveys, depending on country, in Bangladesh, they were between 2017 and 2019. In Ethiopia, it was about 2017, Ethiopia for this paper was in 2020, late 2019, early 2020, so right before the pandemic, and then Jordan was in 2019. And what we do in the paper is we look at first just changes in adolescent outcomes from baseline to these 2 different points in the pandemic. And then we use sort of a difference in difference framework to then compare these changes between adolescents that are more and less vulnerable to the COVID-19 pandemic. And we also look at differences between adolescents who had access to social safety nets through government and NGO provided aid and sort of mitigating these negative impacts. We do have about 5 different samples that we're looking at here. So in Bangladesh, we have a sample of adolescents who are living in Dhaka, so living in urban slums and low-income neighborhoods, and 2 populations that are living in Cox's Bazar, which is one of the poorest areas of Bangladesh. Some Bangladeshi adolescents that are living in communities that are nearby refugee camps, and then a sample of Rohingya refugee adolescents who are living in the camps in Cox's Bazar. In Jordan, we have a sample of Jordanian and Syrian adolescents, and we separately consider those adolescents who are living in integrated into Jordanian communities versus those who are living in camps. And then in Ethiopia, we're focusing on an urban sample of adolescents. And so we'll show sort of results separately by each of these samples, but it also allows comparison of sort of refugee populations and host populations, and also those in more rural settings versus more urban settings in Dhaka and in Ethiopia. Next slide, please. So here I have a few slides that we're going to be looking at some figures with results. And so as a reminder, when we talk about COVID round 1, we're really thinking about May to June 2020. And we're talking about COVID round 2, we're looking at early 2021. So close to a year after the initial lockdowns. The other thing to note, in each of these countries, there were immediate sort of large scale lockdowns that occurred in March 2020, that in most cases, the most strict restrictions were lifted in about September of 2020. So you can also think of these 2 time points as COVID round 1 being during the time of the strictest market closures and lockdowns. And the second time point in early 2021 as being, there were still some restrictions in terms of masks and things, but the markets weren't shut down to the extent that they were in the immediate start of the pandemic. And the other thing that's true in Bangladesh is that, and in Jordan, in Bangladesh and Jordan, is that schools remained closed through both of these periods. So what this first figure is showing is just the difference between baseline and COVID measures. And what I want to highlight is, first of all, we see large decreases in the amount of time spent studying. And I think particularly in Bangladesh, there was very little provision of any type of learning activities from the schools to adolescents at home. There was a broadcast television channel that showed the national curriculum, but there have been studies, and our own data have shown that 10% or less than 10% of adolescents actually accessed those. And so that's really what's driving this reduction in time spent studying. The other thing I want to sort of draw attention to is sort of large the bottom measure that we're looking at here is share of meals with protein, which is what we use to proxy thinking about adolescent nutrition or food insecurity. And we see large reductions in the share of meals containing protein, which is more broadly aligned with other outcomes that we looked at that indicate increased hunger among adolescents as well. And so we see both that there is a large immediate impact, which may be expected due to reduction in market movement, but also we see that these impacts are surprisingly largely sustained when we then look at COVID round 2, and we still see sort of equally large reductions at a time when the conversation thought that these countries should be in recovery, right, because of markets being reopened. Looking at paid work, I think it's unsurprising. We wanted to look at, due to economic insecurity, whether there were any negative, if there was an impact on adolescents working more during the pandemic, but due to the closures in the markets and the fewer job opportunities in general, we do see reductions in engagement in paid work. Next slide, please. So then, as opposed to just looking in general at the changes from baseline to COVID, we wanted to look at whether adolescents that were more vulnerable had worse outcomes than those that were less vulnerable, keeping in mind that all populations that we look at here are vulnerable. And so what we see is that more vulnerable adolescents had larger decreases in the share of meals with protein. And in Jordan in particular, we see that they were less likely, they spent less time studying. And in Dhaka, we have some evidence that that adolescents were more at risk for early marriage, particularly in the later period. So there is some evidence that adolescents who are already at heightened risk suffered more. Next slide, please. Here I'm showing differences in changes in outcomes according to the receipt of aid. I think one of the takeaways here is when you just look on average, adolescents that received aid were not seeing any differences in nutrition in the immediate period, suggesting that aid was not sufficient in the immediate period during lockdowns for food insecurity, though we do see some positive impacts in the Cox's Bazar Rohingya sample and in Ethiopia urban. But in general, we're not seeing that adolescents who received aid are doing better than those who did not. Next slide, please. And then if we further restrict to just look at whether aid was being targeted toward the more vulnerable adolescents, we again see that even among the more vulnerable adolescents, aid is not having much of an impact, with the exception of improvements in food security and access to meals with protein during COVID round 2 in particular. So there's limited evidence that aid receipt was protective for adolescents, regardless of their vulnerability status. And so then just to conclude, I think overall, our takeaway from the paper is that, the social safety net programs, which tend to focus on these poverty alleviation, are insufficient to reach the most vulnerable populations. And they're not responsive to age-based needs. And so we do need to think, if something like this were to happen again, how do we bridge this gap during for young people? While aid did mitigate the negative impacts related to food insecurity, consistent with the fact that, the predominant type of aid was food aid, we do not see similar effects for other critical dimensions. And I also think, if we think back to that first slide, looking at the negative impacts, I think it's notable that there was such a persistence in these negative impacts beyond when the restrictions were lifted. And so we are continuing to collect data with these adolescents and starting to look at data collected in 2022 and 2023 to see what's further happened with these trajectories. But I think, I'm very happy to share these results and looking forward to having further discussion to sort of unpack what we have here. Thank you.
Great, thank you. And Cesar, over to you.
Thank you, good afternoon. It's truly a pleasure to be here presenting the key findings of our paper titled COVID-19 and mental health outcomes of older adults, evidence for Mexico. First, I would like to thank my co-authors, Deb de Graaf, Karina Orozco, Rafael Samper, and Rebecca Wong. I also appreciate having the opportunity to present our paper in this virtual forum organized by Health Affairs. Next slide, please. Since this is a Data Watch manuscript, please allow me to highlight some information about the Mexican Health and Hygiene Study, the MHAS. The study started in 2001, is a national longitudinal study of adults 50 years and older in Mexico. The fifth wave was carried on 2018. Meanwhile, the sixth wave was carried on between November and December of 2021, just before the third peak of the pandemic in Mexico. So the potential impact of COVID-19 in other dimensions, for example, mental health of older adults' life, is captured with the MHAS study. The MHAS content includes health in multiple domains like the socioeconomic conditions, family background, income, access, time use, and psychosocial aspects, and for the disease participants of the study, the conditions in the last year of life. Now, going back to our paper, before the pandemic, we were analyzing changes in the mental health of older adults, given that MHAS already had information in 2012, 2015, and 2018. At the end of 2021, the impact of COVID-19 on mental health can be established. During the early stages of the pandemic, as pointed out by several of the papers before I was presenting, the mental health of the population worsened. Everywhere, the lockdown and social distancing policies had an adverse effect on depressive symptoms, loneliness, and life satisfaction. Mexico was heavily affected by COVID-19, ranking 7th worldwide in reported deaths and 2nd in the confirmed case fatality rates. In addition, the management of the pandemic in Mexico was somewhat chaotic, with hospital bed saturation, long waiting times to get healthcare services, and a shortage of medicines. This combination of an adverse context and the new COVID-19 epidemic produced negative consequences on the mental health of the older adults population. In this article, we are looking at the effect of COVID-19 on 4 mental health outcomes, such as depressive symptoms, loneliness, life dissatisfaction, and foregone healthcare. The figures in parentheses correspond to the 2021 prevalence. Next slide, please. Our paper includes 2 COVID-19 variables: the report of diagnosed infection and experiencing at least one of the 4 COVID-related major adverse events: death of a child, death of the spouse, taking care of a sick family member, and affected financial situation. Being able to compare the effects of 2 COVID-19 related variables opens the possibility to complement the results and the conclusions. On one hand, the infection that has an acute component with probable side effects on physical health, and on the other hand, 4 major events with long-term effects and greater impact on the mental health of older adults. Next slide, please. Something that we have found with MHAS is that the levels of mental health variables remain constant over time. This is the case for loneliness and depressive symptoms. Meanwhile, life satisfaction showed a clear decline between 2018 and 2021. And foregone healthcare showed a gradual and constant decrease over time. At first sight, there is no increase in the prevalence of negative mental health outcomes. Next slide, please. But when we look at the differences by COVID-19, our results show an increased probability of depressive symptoms and loneliness among those who experience COVID-19 infection, and even a higher probability of negative mental health outcomes among those who experience a major adverse event related to COVID-19. And when we look at sociodemographic characteristics, the COVID-19 has a greater effect on women, on those with lower or non-formal education, and those who live in urban communities and among the youngest older adults. So what are the lessons that we learned from the COVID-19 pandemic? Older adults in Mexico are a vulnerable group. Thus, they are heavily affected by COVID-19. The disease increases the risk for negative mental health, and the risk is exacerbated by the report of a major event. We found that using complementary variables like the one for the diagnosed infection and major related events allow us to better understand the impact of COVID-19 on mental health of the older adult population. Thank you.
Thank you. Well, thank you to all of you. And of course, the details of what each of your papers focus on are quite different settings and different topics. But it seems to me they share a theme that I'd like to try to bring out. All of them are the intersection of equity and protection of vulnerable populations and a shock to the healthcare system, in this instance, of course, the COVID-19 pandemic. I wonder if each of you would do me the favor of providing a little context, specifically in the geographic area of your study, of the degree to which there has been a sustained attention to the dimensions of equity that you studied, and whether or not you're aware of any similar analyses through other healthcare shocks. COVID-19, of course, is a horrible shock in many ways, but not the first challenge these health systems have faced. So I wondered if maybe just in the order that you presented, you could provide me with a little bit of context. Esra, could you tell us a little about those topics and their history in Germany?
Our paper is in German. So actually, I've been living in Germany for 5 years, so I'm not quite familiar with the history. So I wish Jonas could have helped me, who is the healthcare expert in Germany. But given the strong social safety net and the universal healthcare system, the vulnerable population, so there is inequalities in healthcare use and access. But when we look at, for example, the hospital utilizations, we see it the other way around. For example, the healthcare utilization or hospital utilization of the more vulnerable population is higher, which shows that they have higher healthcare needs. And these are met in the hospital. So it can be good. So in a sense, it's a good thing that their healthcare needs are met at the hospital, but some of those are ambulatory care sensitive cases, which could have been prevented. So there is still some room for improvement. So, which means that despite having a universal healthcare system and a strong social safety net, still there are some socioeconomic disparities, mostly by education level, but compared to other countries, which are quite insignificant, I think. And unfortunately, I'm not very familiar with the previous shocks.
That was very helpful. Not to worry. Thank you. Jennifer?
Yeah, thank you. So I will say, we have a large team of co-authors working on this paper, and I am part of the data collection. I mostly work in Bangladesh, so I can maybe speak a little bit more to Bangladesh, more so than the other contexts. What I will say is, historically in Bangladesh, even when we initially started doing data collection in 2017, thinking about these social safety nets, is we did not identify many, and most of the social safety net or like aid systems that were in place are more of a provided by NGOs that we've been able to identify, more so than having sort of a national government overarching. So for the pandemic, there was a movement for government to provide aid, although our data is showing that aid really only reached like 10% or so of the samples that we're working with, which are, again, more on the vulnerable side of the population. And so in addition to the work that we've done, there have been other studies in Bangladesh looking at the reach of these social safety nets that have largely found that these programs were not sufficient in general, not just looking at sort of the impact on adolescent populations. So I guess maybe I'll leave it at that.
That's great. And Cesar.
Okay, I think you are right. The inequality, the equity, that's something in the middle, and the context of Mexico. Mexico is a very diverse country. It's a very populated country. We have 127 million inhabitants, and of them, maybe 50 million are aged 60 plus. So, as I pointed out in my presentation, there is a lot of inequality between some groups, for example, women, the less educated, and we have a fragmented health service system that doesn't allow get access to health services of quality. And of course, we have a huge heterogeneity in the 60 plus population. And now we are having population from 60 to 69 that maybe are very different to the oldest old. And it's imposing a challenge to tackle the inequality and how you can access to the health services in Mexico, and try to not make vulnerable the population from the COVID-19.
Thank you.
So if I can just say
Please.
a few things. Jonas just reminded me about the refugee crisis that Germany experienced in 2015 and 16. So Germany experienced a huge influx of refugees during that time, and more recently in 2022 as a result of the Ukrainian war. So actually we are looking at the impact of the refugees on German healthcare system in a recent project. And our preliminary findings suggest that the access to healthcare, for example, was not adversely affected by that influx of refugees, but some of the hospital outcomes, mostly nursing sensitive outcomes, were adversely affected to a limited degree due to that demand shock. But yeah, that's all that I'm aware of. And
That's very helpful. Thank you. Received a question from the audience that I think, Cesar, is probably for you, because it's asking about mental health, and it asks about is it possible to disentangle the effects of mental health from the burden of COVID and all of the other things that happened, as a result that were very socially disruptive?
My first thought is yes, but we have to look into the data, because for now we are looking at the effect of COVID, and we have two variables, just infection, and this is something that maybe is acute, as I said in my presentation, and then we have major events, the death of a child, the death of the spouse, and having a bad economic situation because of COVID. And maybe we can disentangle, but it's for another paper for the next time. And we have to look into the data. And as Jennifer said, MHAS, and I said with the MHAS, it's a longitudinal study. So in 2024, the study is going back to the fieldwork, and we can have the trajectories or the effects of COVID, and trying to see if we can disentangle what part is due to COVID and what is part of some other elements of the dimensions of life in the elderly population in Mexico.
Great. Well, I'm going to close with a question I don't know if you can answer, but it's been on my mind since the very first panel, where there was so much emphasis on models and modeling results and its relationship to policy. I wonder if any of you saw dimensions of the modeling or the efforts to sort of describe the trajectory of COVID with an equity dimension, which isn't something we really talked about at all in the first panel. So did you see models paying attention to inequities? Did you see them helping address or predict inequities, or not? I'm just curious what you might have observed in that regard.
I was thinking in mortality, inequity is best reflected in mortality, and I was thinking on life expectancy. If we can, since MHAS is asking for those who died between 2018 and 2021, and if the cause was because of COVID or disease related to COVID, maybe we can start thinking on how COVID affects life expectancy in 2024 or between 2018 and 2020 and 2021. But I don't know if we have enough sample right now to start working on this inequity, because the healthcare service access in Mexico was really a huge difference for a lot of population that dies because of COVID.
Other thoughts on this, either of you?
I'm not sure this is really an answer to the question, but it made me think about, in our study, we're looking in some ways at sort of, changes in outcomes and then comparing the size of change compared to whether households are more vulnerable or not, as we define it. And one of the things that I think is lost in the fact that, many of our findings is not that there's big differences in the impact of COVID by vulnerability status, but it's still important to remember that the more vulnerable households largely started at a much lower point, right? And then saw this sort of same size negative impacts as those that were doing better. And so the question is, and not something that we explored closely in this paper, but then is thinking, that end point where they are now, like, where does that sort of push those households to thinking about what's possible for those adolescents moving forward, and whether they've been pushed sort of below, I might want to say, like a poverty traps type status that may be more difficult to pull out. And so that all sort of makes me think about, when you're modeling sort of the long-term impacts of this pandemic, that it may be that sort of more vulnerable households are really on a completely different trajectory than the better off households. But
it's very interesting. An area for exploration. I think that's quite interesting. Esra, anything on the modeling?
So I think it's quite complicated to include that equity or inequality. I mean, inequality is the easy one, relatively, but especially equity, because it's quite difficult to measure and to have a common accepted measure for equity at first. And I'm not aware of any studies that has looked at that, fortunately.
Okay. Well, I want to thank you all for your papers and presenting them so well, and for elevating this dimension of the COVID pandemic that played out, of course, around the world. So thank you for that. And